is a very common problem. Cervical cancer, almost all of have heard about this, and it is one of the commonest cancer among women, not only in India, but also all over the world. So let us see how far we can go about this problem. So first of all, let me thank the organizers for giving me the opportunity to present this topic. I thank the College of Physiotherapy and their faculty, Dr. Parag Ranade sir, Patil madam, and Dr. Richa madam. Cancer is a very powerful, strong, and scary word. It brings fear to the mind of the person, and people associate it with death. Not only death, painful death. In a way, we can understand having such a fear, as few decades back, there was no way to stop the progress of such dreadful disease. But as the science is progressing, we have many ways to tackle this problem effectively. In the coming slides, we will see how different countries have achieved this cancer. Currently, if you see the burden of cancer, this is age standardized mortality. Mortality means death of per 100,000 women per year. So India stands somewhere here in between, and the death due to cancer in our country is about 10 to 12 women per 100,000 women per year. Well, there are some countries which are in the red zone, which have mortality 3 to 4 times ours, and there are certain countries in the green zone where the mortality is negligible or very less than ours. But if you see this mortality, over the years, there is decline in the mortality, especially in the well-affluent and advanced countries in the Europe and North America. So if you see the mortality rate in 70s and compare them today, there is a gradual decline of these mortalities in those advanced countries. Unfortunately, not so much decline in our country. So are our women, Indian women, are more vulnerable to cancer cervix? No. If you see the European or North American women, they were same vulnerable 50 years back, but because of different programs and awareness, they have reduced the deaths or mortality due to cervical cancer drastically. Currently, if you see among other countries, Nepal, Indonesia, Maldives, they are very high. India is somewhere in between, where the mortality and the incidence. Mortality means death. Incidence means number of cancer of cervix. If you take 1,000 women, how many of them have cervical cancer? So India stands in between. India currently has about 10 deaths per 100,000 women. And the incidence or the prevalence of this is about 18 to 20 cases per 100,000 women. Now this is the age-specific cancer worldwide in terms of Human Development Index. This X line, blue line is of world, while the topmost line is of low, and the lowest line is of very high human index. So if you see, the incidence of cervical cancer is very high in poor resource countries and very less in where the Human Development Index is very high. Cancer cervix, this programs was first coined by George Papanicolaou, which was the inventor of the pap smear. He was the US immigrant who came to the US from Georgia and started the pathology practice and cytology practice. And he developed a way to stain these cervical cells to identify early cancer. In this line, you see the broken line. The broken line indicates the percentage of women screened, and the solid line is the incidence of cervical cancer. So from 50s, once this screening program took place, the incidence of cervical cancer declined steadily from 40 to almost 10. So there was a drastic decline in the incidence of death due to cervical cancer because of this pap smear program. Unfortunately, in India, we missed this first bus. We could not implement pap smear program effectively due to various reasons. So our rate of death or mortality remained as high as European women in 50s. Now, over the years, we have learned that cancer cervix is unique and different in two ways than most other cancer. Now, let us see what are these ways in which this cancer is different. Imagine you are going on a highway or on a road and you hear this sound. What comes to your mind? That somewhere some emergency is there, some ambulance is passing by. You may not actually see the vehicle, but just by listening, you know that some catastrophe has occurred, some dangerous thing has occurred, some very important thing is done. So you give way, you prepare yourself for that catastrophe. Maybe an ambulance speeding by, you give way to that ambulance. You take cognizance of this sound, which you may not see, but you can listen. Cancer cervix is like that siren. It keeps you telling that it is coming. No other cancer in the body tells you like this. And how long it tells you that I am coming or the cancer cervix is coming? This tells you by shedding abnormal cells from the cervix. And if we pick up these warning things, we can get rid of it by simple OPD procedures. So this abnormal cells shedding goes on for years, minimum 7 to 10 years. So this siren or this danger sign that I am coming, the cancer is coming, is given for almost 7 to 10 years. Now, if we miss the chance, if we ignore this signal, then we may land in invasive cancer. These are the cells which are shed from the cervix. And as you see, from normal to abnormal, the picture shows that how these cells differ. As the abnormality increases, the nucleus in these cells become large, and cytoplasm becomes thin and thin. Not only that, if you see the basal layer, the abnormal cells or the thick nucleus cells are pertaining only to the basal layer. But as it progresses in CIN3, it comes near to the edge or the surface, and more whole thickness of this epithelium becomes abnormal. So this is the stages from normal to low, mid, and high stage or CIN3, which we can identify by examining the cells which are discarded from the cervix. Now, the technique of picking those abnormal cells is by pap smear. Earlier we had the conventional, but nowadays we can have what is called as the liquid base, where we take the sample and dip it in the fluid contained tube and then analyzed automatically by the different procedures. The earlier protocol was to do it every year for first 3 years, and if negative, we used to do it every 3 to 5 years as per the risk of the patient. So we could identify any abnormality occurring much ahead of invasive cancer, and we could easily treat it by simple OPD procedures, which we will see later on. But if you see, take the survey of the general population, especially in India, less than 1% of women have undergone pap testing, forget every 3 years, in their whole life. This also include well-educated women and even health professionals like nurses and doctors. In India, this pap smear program has miserably failed because of various reasons. So our women are not just doing this pap smear, our doctors are not going after this program, and there is apathy from the government that there is a compulsion to do this pap smear every 3 years or 5 years for any job or for any promotion or for any admission. Other reasons for failure this program in India was need expert cytologists to evaluate, and the report used to come after a few days after this taking sample. There was apathy from all stakeholders, and it was not done mandatory for various reasons like insurance, annual increment, etc. There was also some cost involved, about 300 to 500 rupees. Then other screening modalities were developed to address this issue. One is called VIA, or visual inspection after applying acetic acid. Now this acetic acid is simply like a vinegar, which is 3 to 5% acetic acid. When applied to the cervix, any abnormality in the cervix used to look like thick white. This because the nuclei, the thick nuclei in the abnormal cells used to coagulate and give rise to white color. The other test was VILI, or visual inspection after Lugol's iodine. In school, we have done a study where you take a potato, cut it, and put iodine. It used to turn dark mahogany black because of the starch containing in that potato. Similar principle is used here. The cancer cells, which develop very fast and duplicate very fast, they do not have time to accumulate starch. And these cells do not take the iodine stain, because of which they lack the starch. While the other normal cells which contain the starch, they look dark, mahogany or brown in color. So these two techniques were very simple, and health workers, including nurses, ashas, were trained. The photograph after applying this was taken and sent for evaluation. Now, with the advantage of new technology, mobiles with good quality cameras and good connectivity, it helped in implementing these programs. The pilot studies were done from districts in Tamil Nadu and Maharashtra. They were chosen by International Agency for Research in Cancer and WHO, and it showed excellent promising results and could bring down deaths due to cervical cancer. Now, these are some of the pictures with visual impression after acetic acid, and you can see the VI negative, positive, and the cancer, where you can see a thick, well-marked white areas which are VI positive, and these are the areas where cancer starts. So if you find this for any woman, you can take further action. This is another test with visual inspection with Lugol's iodine, and you can see the cells which are dark brown because of starch, and the cancer cells lower down which failed to take this iodine stain because they lack starch. Now there is a second phase in cancer cervix management. What is that? In 1970s, this gentleman, Harold Hussein, detected that the human papilloma virus in warts and cervical cancer, and he subsequently isolated and cloned different strains of HPV, for which in 2008 he got Nobel Prize. So he proved that cancer cervix in women occurs due to infection by the virus, that is HPV. Now, once we know that a cancer is produced by the virus, our progression to tackle this disease was done under two ways. One, can we detect virus, and somehow can we give some vaccine to stop the spread of this virus? So the research went on in these two directions. There were, of course, different HPV or human papilloma virus strains. Some were harmless, some causes wart-like projection, some are linked to the cancer. Many women get infected with this virus during the course of their life. But in almost more than 90, their own immunity or defense system overcomes the spread and duplication of this virus. While in others, their host immunity fails and the virus continues to replicate and producing abnormal cells. Now, this is the natural history of the human papilloma virus infection. It gets infected, a woman gets infected due to sexual activity with the infected partner. And there are years after this infection where the virus may remain dormant and then may start behaving abnormally, duplicating and shedding cells. As the lesion progresses over the few years, the abnormality may increase and lead to invasive cancers. But in most women, the host defense may cause the reduction in the virus. Here, if we can see how the virus lesion progresses from low lesion to high or invasive cancers, and how the regression also can take place if the host defense or the woman's immune system or defense is good. The vaccine was first developed by the University of Queensland in Australia, and the final form was made by researchers at the University of Queensland. This Dr. Ian Fraser and Jian Lu are credited in the Queensland, and they have accorded priority under US patent law. The human papilloma virus vaccine was done on the basis of virus-like particles, which are shared. These two gentlemen also developed the technology that leads to mass vaccine against these two forms of deadly virus, Doug Lowy and John Schiller. By 2006, interim results from a company-sponsored trial were so promising that US Food and Drug Administration approved 2 vaccines for the prevention of cervical cancer and genital warts. One was developed by Merck. It is called GARDASIL, and the second one was developed by GSK called CERVARIX. They were approved and most countries started using them since 2009. This is the injection GARDASIL, which is quadrivalent, which has strains against 4 different types of HPV virus. And this is CERVARIX, which are mainly against type 16 and type 18, which are mainly responsible for development of cancer cervix. Nowadays, we have a nanovalent or a strain or protection against 9 varieties of HPV are also produced by the GARDASIL 9. So these are the basic characteristics of these 2 different vaccines. In the initial phases, 3 doses were required, 0, 1, and 6 for CERVARIX, and for GARDASIL 0 to 6 months. Now, since this vaccine was given, one should not give in a pregnant woman, and one should ask the woman to avoid pregnancy till the course of this vaccination is completed. So ideally, this vaccination are given at a very early age when the woman is not sexually active. So the current recommendation is to give this vaccine before the age of 15 to all girls. If HPV causes cancer cervix, why not develop the test to see if woman is infected with HPV? And that was the basis for developing HPV DNA testing. One of the important landmark was development of this COBAS HPV test. This was done by a Roche company, and it could detect virus-like particles shedded from the cervix for different strains of virus. So it is both a qualitative test as well as quantitative test, and it used to detect the number of viral shed particles and the type of virus. So genotype as well as the number of particles, one could go with this COBAS HPV test. The problem with the test is that, The problem with the test is if you do it too early, before the age of 30, many women get infected with HPV virus and that test may come positive. But as I told you earlier, 90% of these women, because of their own defense system, overcome the virus, and the virus remains dormant and stops multiplying. And as this virus stops shedding its particle, the test becomes negative. So there is no point in doing this HPV DNA test before the age of 30, because many women may show positive, which may not be at risk for developing cancer. Only those women who are infected and continue to shed viral particles are at risk of developing cancer. So this test is recommended after the age of 30. Now we have two tests, the pap smear test and the HPV test for this. Pap smear is an old test and has almost 70 to 80 years of history. Well, HPV test is modern test and is used for about 10 to 15 years. The problem with the pap smear is that you need a qualified person and there can be human error, while the HPV testing is done automated by the machine. So there is no individual error or observational error in the HPV test. So we can have this HPV integration biomarker for what is called as triage of HPV positive women. Women who are sexually active, HPV infection, HPV DNA detection, and those women who have E6 or E7 mRNA overexpression, they are more vulnerable. And those who are vulnerable, a few % of them develop cancer. Now, this HPV test lack of specificity. So there can be colposcopies, over-treatment, it can have a psychological impact and economic impact. If a woman tests positive for HPV, it doesn't mean that she will develop cancer. She is at risk for cancer, but most of them do not develop cancer. You should remember this. Only the thing is, because she is more at risk of developing cancer, we subject her to other tests like colposcopy, and we repeat this test every 5 years to see if she is really developing the cancer, or this test may become negative after 5 years if her own defense system becomes powerful and stops or controls duplication and shedding of this virus. This is the colposcope where we examine the cervix under good light and under high magnification. And if we see any abnormal area on the cervix with the colposcopy, the treatment is very simple and can be done in the OPD in the few hours and cost less than 1,000 rupees. What you see here is a cryogun where liquid nitrogen or carbon dioxide is passed through this gun nozzle, which creates temperature of -180 degrees, and the cell dies because of freezing of water in the cell. So this is one way of killing those abnormal cells by this cryogun. The second way is by the use of electrosurgical procedures or loop electrosurgical procedures, where with this electrode we cut or ablate or remove or dissect the abnormal area and send it for histopathological examination. These two procedures can be done in the OPD, can be done in those patients who show some abnormality of the cervix, not cancer cervix, but pre-cancer problems of the cervix. So if we can detect these pre-cancer problems in the cervix, we can tackle them very easily in the OPD without any admission in few minutes. And these both treatments are very, very effective, more than 90% effective in preventing this cervical cancer. So now we have this primary prevention where it is done by HPV vaccination. The girls and boys should also be offered. Why boys? Boys do not develop CA cervix, but boys are the one who infect girls or women. This vaccine also gives protection against other HPV-related cancers like warts, esophageal cancers, and other genital cancers. Then we have the secondary prevention where we detect early abnormalities in the cervix and can treat effectively. The secondary prevention starts from age 30. And there is a tertiary prevention by what is called as treatment of invasive cancer at any stage by surgery, radiotherapy, chemotherapy, palliative. Cervical cancer prevention should encompass a multidisciplinary, including components from community education, social mobilization, vaccination, screening, treatment, and palliative care. Now, what we lack in India is the awareness of this primary prevention. You ask amongst yourself, your colleagues, your friends, your relatives, how many of them have given vaccine to their girls or to their boys? Hardly you will see anybody giving this vaccine. Why? Because there is apathy. Secondly, there is some cost involved. Each dose costs about 3,000 rupees and you have to give minimum 2 doses. But we spend so much money on other luxuries, we can very well spend on our own health and health of our progeny. And these 2 doses prevent the death from this deadly disease. In 2000, if you see the history, in 2006, the HPV vaccination was recommended. In 2011, it was recommended as 3 doses for boys 11 to 12 years and catch up through 21 years. In 2015, 9-valent HPV vaccine was replaced in many countries with 4-valent vaccine. And in 2016, boys and girls who start series before 15th birthday, only 2 doses of HPV vaccines were needed. In Pune, there is a large study going on under the funding of International Agency on Cancer of Research to evaluate only single dose of this HPV vaccine and its effect in preventive cervical cancer. So nowadays, if you give it before 15 years, it can prevent, a single dose can also prevent the cancer of the cervix. The full result is yet to come. Now, these are the cervical screening recommendation guidelines based on the age. So, age 21 to 29 PAP every 3 years. From 30 onwards, there is a co-testing with HPV, DNA testing and pap smear. Age to start is 21 years. And screening among fully vaccinated currently is same for non-vaccinated, till we fully know the protection level. All guidelines recommend that women who have been adequately screened can discontinue PAP at age 65. Now, this is the risk-based screening and management guidelines. If there is a minimal risk, primary screening followed by routine. If the risk is little high, there is a triage of pap smear, HPV DNA testing, and colposcopy or VIA and villi. For medium risk, colposcopy is a must, and for high risk, the ablative procedures with cryo or LEEP is mandatory to prevent them going for invasive cancers. So these are the novel screening and triage technologies, the automated cytology, HPV DNA testing, viral methylation, and this is the risk-based colposcopy. Now there is something called as artificial intelligence and machine learning, where a health worker can take a photograph of the cervix after applying lugol, iodine, and acetic acid, and the photo is assessed by this AI technology to evaluate what is the risk of that woman for developing cancer. So no expert person is needed. Anybody's photograph can be evaluated at even a remote place. So in our country where there is mass rural population, difficult in getting expert opinion, we can avail these technologies. Now, this is a combined vaccination screening program in low resource setting like ours. The first dose of vaccine should be given before the age of 15, followed by screening. One can suggest by HPV screening after the age of 30 once in 5 years. The HPV DNA testing costs about 1,500 rupees. 1 dose of HPV vaccine cost about 3,000 rupees. And the pap smear cost about 300 to 500 rupees. So these are the two proven opportunities to prevent cervical cancer. Number one, in early age, vaccination. And number two, after the age of 30, screening with either HPV DNA or pap smear. If you follow these two modalities, we can very well control the cancer of the cervix in our population. Now, if you see a case of Australia, why we have chosen Australia, I will tell you. It was the first country to pass legislation for HPV vaccination for girls and boys. And currently, all girls and boys are vaccinated before the age of 15 in Australia. And they have an excellent result after starting this program, as the age standardized death because of cancer has been drastically reduced because of this mass vaccination policy. Earlier, breast cancer and cervical cancer were the leading death of cancer in women. In India, still they are the leading cancer, breast and cancer. But in Australia, because of this program, the breast cancer is number 2 and the cervical cancer has become the last because of this program of mass vaccination. This is the picture in India. The red line is cancer breast, which shows steady increase, especially in the metropolitan cities like Bangalore, Chennai, and Delhi. And reduction in the cervical cancer, though it is not drastic, there is a reduction in the cervical cancer over the years from 1987 to 2012. This is the chart. Now, in India, the WHO has given this latest statistics. The crude cervical incidence is 18.7. The cumulative rates of cervical cancer is about 2%. This is the cervical cancer mortality, and there is a population-based cervical cancer registry. Unfortunately, we do not have any government or program for HPV vaccination. Now, if you see this different country, even the Sri Lanka, if you see girls age 15 years old that received the HPV vaccine, the number is 82%. Switzerland, they started this vaccination way back in 12. But Thailand is 66% of girls before 15 received HPV vaccine. But in India, we do not have any data, as there is no government program to vaccinate our girls before the age. Now, this is the secondary prevention by screening programs. And the screening programs, if you see, fewer than 1 in 10 women have been screened for cervical cancer in last 5 years. Our screening programs are not that effective. The treatment and supportive care, that is the tertiary programs, we have the radiation oncologists, surgeons, oncologists, and where we can offer them when there is invasive cancer. Coming to the end, what are the targets for India which are set by WHO cervical cancer strategy by 2030? Now this target tells that 90% of the girls before the age of 15 should be fully vaccinated, where we are lacking so much. 70% women should be screened, and 90% of the women identified should receive proper treatment. So coming to the end, cervical cancer is unique in many ways. It gives warning signs for years.
Thank you.
Only cancer for which vaccine is present. So in a way, this is the only cancer for which you have a preventive vaccine. And in pre-cancer stages, it can be treated in OPD with simple measures. Shall I stop it? Hello? There is some disturbance.
Sir, can you mute Dr. Aparna Sasane? I think you're the host, so you can mute her.